good afternoon or good morning for some of you. Thank you very much for joining us today for another Connected Care webinar. My name is Lindsay Farina and I will be your host for today. For those of you who are joining us for the first time, welcome. For those who are returning, thank you. To provide a little background, we offer educational webinars, podcasts, and when we can, in-person events. As we're giving people time to log on, I thought we could start some polls. So if in the chat, you could please enter where you're joining us from, what your role is in your organization. We always enjoy seeing where people are from in the various roles within clinical practice. Don't be afraid to put in there, just even where you're located from. Oh, thank you, Chelsea, for starting the ball. Mississippi. Oh, Ontario. Very nice. Well, we've got a wide array of people, so thank you very much for joining us. Indiana, I'm also from Indiana, so welcome to you. Another Indiana. Okay. Just a couple of housekeeping points before we begin. Today's webinar is being recorded and a link will be provided to all the attendees, those have registered within 2 weeks. Previous webinars can be found on our YouTube site, which is Baxter Healthcare US, and this can be found by entering @Baxter Healthcare US in the search bar of your browser. We will be hosting a Q&A session right after the presentation where your questions will be addressed live by our guest speaker. Please enter your questions through the chat or the Q&A box throughout the presentation. The Q&A box allows us a little easier to visualize as chats are coming through, but either we will accept. Today, it is our pleasure to have Donna Bond presenting the role of accurate respiratory rate monitoring and improving patient outcomes. Donna graduated from Community Hospital of the Roanoke Valley School of Professional Nursing in 1981 with her diploma in nursing. She continued her education, receiving a BSN from MCV VCU in 1994, her MSN from the University of Virginia in 1998, and her DNP from Case Western in 2009. She started her career on a medical surgical unit, transitioned to critical care where she spent 12 years as a staff nurse and preceptor. In 1996, she left the bedside to become a case manager. And after she completed her MSN, she began her journey as a clinical nurse specialist and focused on the care of pulmonary patients. Over the past 25 years, she has focused on chronic ventilator weaning of patients, reducing pneumonia rates, starting a nicotine cessation program, various performance improvement and research projects, and is currently focusing on increasing awareness of pulmonary compromise related to opioid administration. She now works for a level 1 trauma system using her pulmonary experience to focus on patients with traumatic injuries. Donna was a founding member of the Virginia chapter of Clinical Nurse Specialists and served as the first president. In addition, Donna has been an active member in the Respiratory Nursing Society Interprofessional Collaborative, serving in multiple board positions, including president. She currently serves as the board of the Respiratory Compromise Institute, and she carries a certification as a critical care clinical nurse specialist, and a certified tobacco treatment specialist. She has received honors from the Respiratory Nursing Society, Sigma Theta Tau, the Tau Phi chapter, Virginia Nursing Foundation, and Carilion Clinic. She was induced in the first class of CNS Fellows in 2019, and Donna has presented at many national conferences as both a speaker and poster presenter. She has published her work with adolescents in tobacco prevention, asthma education, and the clinical nurse specialist role. With all of those achievements, it gives me great pleasure to introduce Donna. And Donna, I will let you start your presentation.
Thank you very much. I hope everyone can hear me and welcome on this Thursday afternoon. Sometimes the weeks seem to fly and sometimes they seem to take a while. So I hope you will enjoy this. I'd like to thank Baxter for asking me to speak about this topic. It's very near and dear to my heart. As you've heard, I've been focusing on pulmonary for the last 25 years. And patient's respiratory status is very important to me. I'm hoping that you will learn something. I hope that some of this is going to be information that you know or suspected, and some of it may be new information. Uh, okay. I am a member of the Baxter's Contact-Free Continuous Monitoring Advisory Board, and Baxter did supply the software for the second performance improvement project that I'm going to talk about today. Um, so what I'm going to do is I'm going to talk to you about what I have found out about respiratory rate. It's such a basic um, indice that we don't always think about it as being important. And like I said, some of the information may be new, some of it you may have suspected. I'm also going to talk to you about a couple of performance improvement projects that I have done at my institution. I've done several around related to respiratory compromise and respiratory depression. And the first one has to do with just what we document as far as our respiratory rate. And the second one is using the contact-free continuous monitoring technology, or the CFCM. I have, these were kind of like my beginning studies about respiratory rate and opioids, and that will all make sense as I kind of talk about what I found. Uh, I am in Southwest Virginia, which, if any of y'all have read the book Dope Sick, it was based a little bit further southwest than I am. So there is a huge opioid problem, but it's not just the people taking opioids outside the hospital. We also have a problem with our administration of opioids. And so I'm going to talk about that just a little bit. So, did you know that abnormal respiratory rate is the best predictor and the most sensitive of all the vital signs of predicting impending respiratory or cardiac compromise? And almost 14 out of every 1,000 hospitalized patients experience respiratory failure following surgery. That's according to a health grade survey. Respiratory compromise increases the patient's mortality by over 30% and increases ICU stays by almost 50%. And 7.1 billion was spent on respiratory compromise in U.S. hospitals in 2007. And that's been quite a while back. And so we know that the expense of patients experiencing respiratory compromise has just increased. Failure to recognize and respond to early signs of patient deterioration is one of the most common avoidable safety risks for our patients. 60% of arrests are due to respiratory compromise are avoidable. Opioid use is associated with adverse effects, and most importantly, respiratory depression. 16% of adverse drug events are related to opioids, and 29% of those could have possibly been prevented by adequate monitoring. What is respiratory compromise? Respiratory compromise is that period of time when a patient is starting to deteriorate, but specific interventions can prevent or mitigate the progression to respiratory failure. So it's that in between time, but when the patient is normal and breathing fine, and on the other end of the spectrum of having respiratory failure. This is a great article that I found when I was doing my research from Lynn and Curry, and they talked about 3 reasons for unexpected death in hospitals, and it's related to respiratory compromise. These 3 are. And it also helps explain why the conventional monitoring by oximetry, which we've used for years and years and years. I remember when oximetry was kind of new and we were all excited about it. This may not be the most sensitive or the best way of monitoring our patients for respiratory compromise. The first type, the hyperventilation compensated respiratory failure is when there's a microcirculation failure. And that's when the body loses the ability, the circulatory system loses the ability to deliver adequate oxygen to the tissues. And this can be related to heart failure, to sepsis, to pulmonary embolism. The patient becomes hyperventilate, they start hyperventilating, which leads to respiratory alkalosis, which leads to a rise of their minute ventilation, and finally they develop a metabolic acidosis and a drop in their oxygen levels. I want to talk about type 2 in just a minute. Type 3, this is the sudden death in the hospital that's related to sleep apnea. Most of the time it's undiagnosed sleep apnea. It's arousal dependent survival. And so the patient has hypoxemia during apnea, and then they have an arrest related to that. When a patient who doesn't have diagnosed sleep apnea comes in and we give them an opioid, we usually hear the oximeter going off. And by the time we get to the room, or by the time we checked it, the patient has kind of woken up and has recovered. And so the oximetry is fine. And so we're not sure why it keeps going on. And so that continues until the patient doesn't wake up and increase their saturation up. And if you've ever wondered why most hospitals have a patient on a PCA pump and they have to have capnography hooked up, because when PCA pumps first came into being too, we were told, oh, the patient can't overdose on it, is because they have to be awake to give it. But we do know that patients with sleep apnea can absolutely overdose themselves with PCA pumps. And so we hook up capnography to them to tell us when the patient is becoming too sedated, and they may not realize that. Okay, the type 2 is the CO2 narcosis. And I'm going to argue that capnography should really be used to monitor any patient that's receiving opioids, because this is the type 2 happens with opioid depression or anything that can cause hypoventilation. The PaCO2 rises and there's a fall in the SpO2 over about 15 minutes, or it can take several hours to happen. This causes central depression of the respiratory drive, and supplemental oxygen can hide this. And so with this graph, hopefully you can see my little pointer here that I'm using. A patient that's on oxygen, and we're just monitoring their saturation of the SpO2, it's way over here before their saturation will drop below 90, which is what most of our oximeters are set at. If they're not on oxygen, you can pick up on it a little bit better. It happens right about here. But if you're monitoring their capnography and you've set it for the normal parameters of the capnography, this little green arrow shows you how much sooner that you can pick up on that your patient is getting into problems with their respiratory rate. In 2020, January of 2020, the lack of respiratory monitoring by our hospitals came to the attention of the Joint Commission. And so they published a mandate that we need to monitor patients that are identified as being high risk. Well, y'all all know what happened in 2020. And I think because of COVID, we were so focused, rightly so, on saving our patients' lives with this new virus that we didn't really know how to handle, that this mandate's kind of gotten pushed aside, and they've kind of moved on to other things, from what I understand, when Joint Commission comes to visit us. We all know, the pain management and monitoring for things like that. And this mandate just did not seem to rise to the significance that past mandates by Joint Commission had risen to. So I believe there's not enough attention paid to this. But who are high risk patients? And so I went to the literature and I looked. I said, well, okay, so what does the research show? So usually they're male. Older than 60, absolutely if they're older than 75. Opioid naive patients also have a higher risk. These are patients who have not had an opioid in the last 30 days. If they have a history of sleep apnea, sleep disorders, so that's where that comes in, a history of heart failure, smokers, if you're getting concurrent sedatives, that's also very important because a lot of our patients that receive opioids will also receive a sedative with it too, especially at night to help them sleep. If they have a respiratory rate less than 10, that was kind of obvious. If they're not breathing well to begin with, they have less chance of breathing well. And then abdominal thoracic surgery or anesthesia for greater than 3 hours. So if you look at this list, that covers a lot of our patients. And what some hospitals are doing is they've started doing the stop bang assessment on all the admissions. And so that'll catch the patients that have undiagnosed sleep apnea, but it doesn't catch some of the other patients that end up being at high risk. So while I was in the literature, I kind of looked at the evidence related to respiratory assessment. And so I started by looking for nursing assessment plus respirations. I looked for counting respirations. I got all the articles that had to do with that, added some limits like English, adults. I'm an adult clinical nurse specialist. And then I put a few more limits. I got rid of my duplicates. There was a lot of articles and research on ventilators, on pain management, and on oral care when I put those parameters in. So I weeded all those out. And so I ended up with 88 articles that I ordered and reviewed. Then I did an ancestry search with those articles, which is when you review the references of the articles that you have, looking for the original works. You always want to go back to the original works to see what they said and not how someone has interpreted what they said. And that led me to a few more articles too. So I ended up with about 39 articles on this topic of respiratory rate, counting respirations, anything to do with the respiratory rate assessment. And so four themes really emerged when I did this. Respiratory rate is not documented. So we're wondering, does this really, do we really assess it? Um, the articles, a lot of them were qualitative observational studies. And what they found was at least 10% of nurses, um, less I'm sorry, less than 10% of nurses document the respiratory rate when they document other vital signs. So they'll document the blood pressure, they'll document heart rate, they'll even document the oxygen saturation, but they don't document the respiratory rate when they do that. Even with patients that have a respiratory disorder, they don't document the respiratory rate. Surgical nurses were a little bit more likely to document respiratory rate than medical nurses. And then, so if it's not being documented, let's talk about accuracy. Is it accurate? As far back as 1957, I found an article that a doctor had written how respiratory rate is not accurate. Um, and is it valuable? Are we just doing something because this is what we've always done, which is never a good reason for doing something. And most healthcare professionals will admit that they value other vital signs above respiratory rate. They believe that a change in blood pressure, heart rate, or rhythm, or oxygen saturation is the earliest warning sign of impending disaster. And that's not true. It is respiratory rate. Respiratory rates, when they're done accurately, counted accurately, have been found to be the best indicator of cardiac arrest when heart rate and blood pressure were not predictive. A change in respiratory rates, an early sign of increased intracranial pressure, an indicator of sepsis, and like I said, impending cardiac arrest. So all other body systems kind of dependent upon the respiratory rate. Respiratory rates greater than 30 have shown a mortality as high as 85%. And noticing a change of 1 to 2 breaths per minute can be the difference between running a code and preventing a code. But you have to accurately count your respiratory rate. So the fourth theme that kind of emerged was how do we improve accuracy of the respiratory rate and the documentation? And I'm going to talk about that in a little bit. A couple of articles I want to highlight. This is the study from 1957 that Corey did. And he compared the documented respiratory rate of 58 patients to the actual count of the respiratory rate that his research staff did. And so out of the 58 patients, 57 patients have a documented respiratory rate between 18 and 22, with 40 patients having exactly a respiratory rate of 20. So he compared that with what his research team found, and they found that the respiratory rate was actually between 11 and 33. So between that study and then this study by Badaway, this led to my study about accuracy of respiratory rate. Badaway found that they observed 36,000 vital signs. Now, I couldn't look at, well, actually, I did look about that many. But anyway, they looked at the documented vital signs, and they found that heart rate, blood pressure, they all follow a normal distributive curve. Respiratory rates do not do that, however. They are grouped around 18, 20, and 22 and do not follow that normal distributive rate. So other studies have duplicated this and found Keene in 2017 found that 86% of patients had a respiratory rate of 15 or 20, I guess, depending on if they looked like they were sleeping or not. So the conclusion of that article was that these were probably estimated as opposed to being manually measured. So what I wanted to do was look at the similar thing, look at my respiratory rate of patients with a particular population of patients. And so what I chose to do was a retrospective study, and I looked at all the patients at my institution that had either had a rapid response and or a code blue. Because I figured they had some type of event. So I should be able to find that the respiratory rate's going to change before that event happened, since it's the first vital sign to change. So I looked at 716 patients. There were 1,040 events. Some patients had multiple events. Some people had a rapid response that led to a code, etc. So what I found was a mean age of 66.3. My patients ranged in age from 19 to 97. 58% were male. Their hospital length of stay was from 1 day, and one patient stayed 270 days, but they gave me a mean of 6.7 days. So these are the results. I found in comparison to the heart rate and the blood pressure, 83% of the respiratory rate were in the normal category. That's compared to 65% for the heart rate and 54% for the blood pressure. Now, remember, according to the literature, according to the research, the respiratory rate is the first thing that changes. And so, for the most part, either the respiratory rate was not correctly documented or it just wasn't there. It wasn't monitored. So, this finding really was not surprising after what I had read in the literature, but I did find something that I was not expecting. And that's one of the things I always love about research is I go in looking for one thing and then I find something that I wasn't expecting. And so I found that there may be a possible relationship between the code blue or the rapid response and the patient receiving opioids. The majority of the patients that I found had had an opioid within 72 hours of the event. And the amount of opioids I was way impressed with. For a med surg or a PCU, this was a lot of drug. And I did not calculate the MMEs or the morphine milliequivalents at the time. I wish I had. And I did that in a later study. But I wasn't expecting to find this. It was just a piece of data I was collecting. So that led that that has led to several other studies. So getting back to the literature, what can help us with the respiratory rate of these missing respiratory rates? What would help us with documentation? So, of course, education. Education is always the first thing we do. Well, we've known that respiratory rates not being documented or not accurate for over 60 years. So I'm not sure that education is going to work now. I do think that people need to understand how important respiratory rate is. A lot of facilities use early warning systems. We have one at the hospital that I work at, and the respiratory rate is weighted very heavily in that. So if you have an inaccurate respiratory rate, your early warning system is not going to work as well. Um, we need to make sure there's still some low tech around, that we still have clocks with second hands. Most of us have switched from analog to digital clocks, and so it makes it more difficult to count respiratory rates. So you need to have either a clock with the second hand, or they have apps that you can hit on your watch or your phone that will tell you when to start counting and then when a minute's up, and you can tap the watch for each time the patient breathes, and then it gives you the accurate respiratory rate of how many times that you've tapped. Uh, we currently have capnography, and it's not being used for several reasons. Patients are not fond of it. The little reservoir makes them uncomfortable. But there's also some wearable devices that the patient can be attached to the patient to their chest, and it will monitor their minute ventilation, minute volume, or their chest wall movement. So those things do exist. Um, so I've shown you the evidence of what an accurate respiratory rate, why it's important. And another avenue for us to another technology that we can use is the contact-free continuous monitoring. So these were developed initially by Hill-Rom, who, Baxter now owns the technology. And these are considered smart beds, and they have a monitor in their bed frame that senses movement of the chest, and it calculates the respiratory rate and the heart rate every few seconds. There's nothing for the patient to wear. There's nothing for the nurse to turn on. It sends a signal through the nurse call system if the uh, heart rate or respiratory rate drops out of the set parameters. You can look at the bed, you can get the numbers off the bed. They can also flow to a monitor. So I'm a pretty doubting person. And so, I've been a nurse a long time, and I've learned that not everything that someone is trying to sell me is works the way that they say it does. And so I've developed a little performance improvement project to see, is this technology really, really accurate? So while I'm interested in respiratory rate, I know other people are interested in heart rate. So we set the project up to do that. We set the project up to evaluate the accuracy of the Centrella Smart Bed with the contact-free continuous monitoring with a gold standard. The gold standard of respiratory rate is to count respiratory rate for a full minute. The heart rate, the gold standard we used there was the telemetry that the patient was on. We did this on a cardiac PCU. And then I wanted to see comparing the early sense respiratory rate against what was documented in the chart for the patient. We also looked at, because this is an additional alarm for the nurse, we looked at how many times it alarmed and added to their day. The statistician determined we needed 100 data sets with the respiratory rates and the heart rates. And so we had a team of two nurses, myself and another nurse who went around. So we had 50 unique patients, and we would go together as a team, but we wouldn't talk to each other. And one of us would stand and count the patient's respiratory rate for a full minute and look at the monitor, get the heart rate off the monitor. The other person would get the same two numbers off of the bed. Our patients ranged in age from 36 to 93 with a mean of 71.3 years, 68% male, mean hospital length of stay of 10.6 days. The majority had a cardiac diagnosis. Remember, we were on a cardiac PCU. 32 had a pulmonary diagnosis, and the the ones that were left had either renal or neurology. So the results of my study, the first is to compare the telemetry heart rate to the Hillrom Centrella Smart Bed contact free. No statistical or clinical difference. We used the Wilcox signed rank sum test to, sorry, I am near the emergency room, so occasionally there's announcements over the intercom, but no difference in the telemetry versus the contact free. And then objective 2 was the respiratory rate, which I was mostly interested in, and it was the same. There was no clinical or statistical difference in those respiratory rates. And then this one kind of surprised me. There was no difference between the documented respiratory rate and the bed respiratory rate. But I don't know. Maybe they figured out that they could get the respiratory rate off the bed. We asked them not to, but maybe they did. And so maybe that was what was in the chart. I'm not sure. So an interesting finding when I was pulling the respiratory rates from the electronic medical record was the number of respiratory rates documented. The standard for documenting a respiratory rate in a PCU is every 4 hours. So only 71.3% of the patients had their respiratory rate documented within 4 hours of us checking it. So we were missing a respiratory rate on about a fourth of the patients, which supports the research that we don't document respiratory rate. Also interesting that there was 455 entries of respiratory rate on one patient. And I'm like, how could that be? And when I went back and looked at the chart, I found that patient had been in the ICU. And so the monitor will carry over to our charting system. You just have to click it. And so someone had clicked 455 times what their respiratory rate was. So I just thought that was pretty interesting. So in conclusion, the contact-free continuous monitoring was just as accurate as a 1-minute manually counted respiratory rate and the telemetry heart rate. I feel like that this technology can really help us.
Adult level 1 trauma, ETA, 8 minutes. Adult level 1 trauma, ETA, 8 minutes. Lifeguard 10.
Sorry. We also did though with this a cost analysis, and I'm going to show you some of that. But the technology does need to be used with the proper population. For example, this may not be appropriate for patients with Parkinson's or with atrial fib. We did find that those numbers were not as accurate as patients that had a normal rhythm. They'd be sinus rhythm, sinus tach, sinus brady. That all those kind of counted as normal. And patients that were on comfort measures, sometimes the alarm would be annoying, especially if we figured out how to turn it off in the room, but you knew your patient was going to die. It does give you early warning though when their respiratory rate changes. So I'm not saying don't use it for palliative care, but you just need to keep that in mind with your patients. So what we estimated when we did a time study was there was a 1-minute saving for each respiratory rate. And so on a med-surg unit where vital signs are done a minimum of every 8 hours or 3 times in 24 hours. On PCU, it's every 4 hours.
Staff, if you had any unused IV poles, please return to triage. If you have
6 times in 24 hours.
Triage.
And then looking at the starting salary for a clinical associate, which was $12.50 an hour, 20 cents a minute when I did the study, this is how we estimated what the cost savings would be for using these beds as far as the staffing. So I do have a reference list with all the articles that I reviewed with that if you want that, just let me know. My email's coming up on a slide here in just a minute. I do want to go over the key points again, that respiratory rate is the most sensitive indicator for impending patient compromise if it's done correctly. Respiratory rate must be counted 1 full minute to be accurate. Do not depend on pulse oximetry to thinking that it will give you an early warning. It does give you a warning, but it's not necessarily early. You need to closely monitor your high-risk patients for respiratory compromise, in particular if you're giving them opioids. And there is technology out there that can help us if we use it. So hopefully, if we use it correctly, we can prevent upgrades to the ICU by intervening early to prevent respiratory compromise to running into respiratory failure. So I'm ending with a picture of my cat. He lets me count his respirations quite often just to get some practice in. And then you have my email. So thank you very much.